Afternoon, everyone. Thank you for coming along to what we hope you will find to be an interesting presentation and discussion. inter-rai offers the most widely used assessment and clinical decision support systems for aged care worldwide, which we believe would bring important advantages to our own program here in Australia. Today, we hope to provide you with information about inter-rai systems and how they might be applied in Australia. Here is the summary of the grounds that we hope to cover today. I'll be joined by my colleagues Bonnie Pimm and Ronald Dendere, who will tell us about training and application in the clinical care environments and about how inter-rai systems relate to the various data systems and standards that we so much require in Australia. First, I'll begin with a broad overview of inter-rai and how its systems are designed and utilised. In organisations like hospitals or in the aged care program, one sees organisations developing what I call compilation assessment systems. The organisations gather together what they consider to be best of breed or most appropriate screening tools, risk assessment tools, and scales to compile a standardised approach to assessment for their organisation. The advantage of this approach is that it's fairly easy to do. It does require some research into the literature potentially, or just gathering scales and other applications from those that are in common use. And one can be fairly confident that they've been well researched and validated in terms of the individual components. But the compilation approach does come with problems. Individual observations or items are inconsistently designed amongst the various scales and tools that are compiled together. There may be duplication of observations. For example, a phenomenon such as mobility may be required for several of these scales, but in each scale it is configured or scored in a different way. Third, some information that's required for assessment may be missing because it's not included in a scale or in a screener. So organisations then fill in the gaps by making up items that often have poor psychometric properties. And finally, organisations tend to select their own batch of applications, and this leads to lack of conformity amongst the various software solutions that are out there in the market. Let's take a look at how data is assembled in the Australian Aged Care Program. And I've just picked an example here of an individual who approaches My Aged Care with a view to finding a place in a long-term care facility or an RACF. So if one enters the My Aged Care website, there's an online self-assessment there that really revolves around instrumental ADLs and personal ADLs, quite good. Having passed through that process, an individual would likely be assessed for eligibility for long-term care by an aged care assessment team. And upon entry into the RACF, a process of clinical care begins and usually starts with a comprehensive assessment. Shortly thereafter, there will be an assessment to determine the level of reimbursement. That's the ANACC system, which is applied. And finally, a short time later, the person will be assessed in the framework of the Quality Improvement Program or against the National Quality Indicator set. So in this chain of assessments, there are in fact 5 assessments. The content of each assessment is similar. Same kind of problems are recorded, but each one of them has its own specific data set, perhaps a series of scales and other applications, but there is minimal data conformity amongst these various assessment processes. So in effect, what we have in Australia is a collect many times, use once approach to the recruitment of information. There is an alternative to the use of a compilation approach to developing assessment systems. And this approach we could call integrated assessment systems, or in some circles, this solution is called second generation assessment systems. The approach here is to develop simultaneously a conformant data set that is used to support a variety of applications such as scales, screeners, case mix tools, and quality indicators. The advantage here is that there is only one way to describe each phenomenon that feeds each of these applications, thus reducing the amount of data duplication and obviously producing a much higher level of data efficiency. So in effect, this approach adheres to the collect once, use many times principle that we hear so much about. So what's out there in the way of integrated assessment systems? What indeed is the best of these? The Australian IT Council commissioned some work at the University of Queensland last year to address this very question. And the Centre for Health Services Research generated a report called A Survey and Evaluation of Comprehensive Geriatric Assessment Systems for Residential and Community Aged Care. It looked at the entire panorama of such systems worldwide through a process of literature review and subsequent appraisal against a whole set of pre-prescribed parameters. And out of this work, it was clear that inter-rai is the superior solution for a whole variety of reasons. This report is available on the ITC website. So what does an inter-rai system look like? First of all, there are a set of clinical observations. People call these questions, but they're largely observations made by clinicians providing care. There are a suite of applications that include scales to measure severity, screeners to identify problems and estimate risk, so-called clinical assessment protocols that help clinicians prioritize interventions, quality indicators to assess facility performance, program performance, and case mix tools to understand cost, and in some jurisdictions, these provide the basis of payment. Generated from such applications and the data, the observations, there are summary profiles that summarize the information that pertain to particular individuals. Example of an inter-rai observation. It's taken from the long-term care facility assessment system. And as you can see on the left, there's quite a lot of detail in the way in which the amount of help that a person needs to walk is described. And this data is prescribed in this way to make sure that you get reliable observations amongst the various assessors who may be assessing an individual or group of individuals. And beyond what's in the actual form or on a screen, there is a detailed explanation in a manual that supports those definitions that you see on the left. So the whole process has resulted in inter-rai items becoming very robust, reliable, and valid from a psychometric point of view. And if not to state the obvious, inter-rai systems include accurate data, which is collected once and used many times. Taking the concept of standardized assessment even further, inter-rai has built a suite of assessment systems that pertain to care delivered in a variety of populations across a variety of settings. And here is just a set of examples of inter-rai systems that predominantly relate to aged care, but it's worth understanding that inter-rai has now developed systems for paediatric care, adult care, as well as for people in older age groups. So you can see there are community systems. Some of them are quite brief and used for populations that have got relatively uncomplicated needs. Some are quite extensive where there is a very complicated set of requirements amongst the users. There are a similar suite of systems available for use in hospital, again for all hospital patients, but also there are specific tools for aged care, such as the inter-rai acute care for comprehensive geriatric assessment. And then there are inter-rai systems for institutional situations, including the inter-rai long-term care facility that we've referred to already today. An important design feature of this suite of systems is that each of the individual systems contain a set of core items and scales that are identical and common to every system that inter-rai produces. In addition to these core items, there are setting-specific items. To give you an example, if a person, say an older person's being assessed in a home care situation, the physical environment, for example, the number of steps to get into the house, where they keep their food, who else lives with them, is quite important. But if the person was living in a long-term care facility, a nursing home, those matters not be really relevant to that context. So that's the setting-specific items that go with these systems. To conclude, I just want to say a few things about the inter-rai organisation. I'm a member and have been involved for about 20 years, so I've contributed, along with some of my colleagues, to the development of some of these systems. It's a not-for-profit international research collaborative. It is contributed to by about 100 plus volunteers, mostly academics and policy-oriented people and clinicians from about 40 to 45 nations. It was established in 1992 and has a mission of improving the lives of vulnerable people through assessment and research. Its current footprint is growing and is substantial, and there are quite a number of countries where these systems are mandated for use in across the nation, and that includes Belgium, Canada, Finland, New Zealand, Singapore, Switzerland, and the USA, just to name a few. Now I'd like to hand over to Bonnie Pimm, who's going to talk about some of the practical aspects of the use of inter-rai systems and also tell you something about how training is conducted. Thank you.
Hi, my name's Bonnie Pimm. I'm a research nurse with the University of Queensland, and I'm also a clinical nurse in a large public hospital where I'm part of the geriatric assessment team. I'm an inter-rai fellow, part of the Network for Acute Care, and also part of the training committee. And I'm going to present to you today an approach to assessment and training. So an inter-rai system's not one-dimensional. It's not just a form, but it's comprised of several elements known as a third-generation assessment system. Inter-rai has a data collection form which includes administrative data for identification purposes and also clinical observations, which provides important information and is useful for day-to-day care and planning. The provision of a training manual ensures reliability and maintains consistency among assessors. And applications or outputs are generated by software via a range of algorithms behind the screens. And these include things such as diagnostic and risk screeners, severity scales, clinical assessment protocols, quality indicators, and in some instruments, there's also case mix groupings. So the assessment itself is designed for use by trained staff. It can be performed by a single assessor or contributions from multiple people. The manual itself is useful to use side by side with the assessment. It consists of items and definitions which are useful for structuring your clinical assessment. And this information that's being collected can also be really useful for other health professionals. The assessment itself is based on observations, so it does actually require direct questioning of the resident, but also sometimes relatives or support people if they have any available. So it's not a questionnaire, it's not a tick and flick sort of piece of paper with yes or no answers. It is based on observations from assessors and from people who actually know the resident and are there 24 hours a day, identifying what that person actually does. Because as we all know, sometimes what the information you're being given by the resident isn't necessarily an accurate reflection of their ability to do things. So the assessment itself does require careful consideration of the person's competence. Apart from family and staff, it's really useful to actually access additional information. So it could be GP letters, it could be specialist assessment, it could be recent hospital discharges or any other information that's available. So the inter-rai assessment system is a single assessment system which is collected once, is interpreted by the software, and then provides a whole range of different outputs specific to the individual. So there's applications which are generated through the assessment, and these are really useful to create what we call a patient profile, and this identifies individual strengths and needs and can be used to assist to create robust, effective treatment and care plans. The beauty of this assessment is that when a person's care needs change and the assessment is updated to reflect this, it automatically readjusts all of the risk screeners, for example, falls risks or pressure injury risks, and it can also trigger areas where interventions might be applied to support care in particular areas. Training is a critical ingredient of a successful inter-rai assessment system implementation to preserve the reliability of the instrument and also the quality and the accuracy of the data. It's important to preserve the inter-rater reliability between assessors across organisations and settings. Inter-rai differs from the standard questionnaires with its own set of outputs or applications. Therefore, users need to be familiar with this new terminology, so those things such as the scales, the screeners, clinical assessment protocols, and quality indicators, but also understand and utilise these applications in their daily workflow, including monitoring and care planning. However, the training is not just about how to score the instrument. There are other considerations such as accessing and navigating the software systems which host the instrument. And while it might not be specifically the role of the educator or trainer, there might be an element of implementation and change management, particularly if this is a new service or if you're new to inter-rai. So a lot of organisations might already have existing training strategies in place, particularly the larger ones, or they might need to identify specific needs and training requirements. The train the trainer model is usually the method of choice, and what we have found works best when we're implementing into either pilot sites or existing sites as well. The variety that online training offers means that employees can learn according to their style and immediate needs, and a lot of staff can access and perform the training at the same time or over a 24-hour period, particularly when you've got shift workers who are involved in needing training. So the training can actually be uploaded onto existing learning management systems, which minimises initial development costs and service fees as well. There's not only the assessors who will need to be trained, but you might have a bunch of other stakeholders as well. So that could involve multidisciplinary staff, administrative staff, medical staff, and potentially external stakeholders as well. So it's important that you have different types of training requirements covered as well. Quality improvement and compliance. So obviously, if you're having everyone trained and they're all being trained on the same system or the same assessment, then that does improve your quality improvement and compliance as well. And it also improves your sustainability. So if you imagine with an inter-rai assessment, once you've actually learnt how to do one assessment, the core set of information and the way that the assessments are set out is essentially the same across the whole suite. And so not only if staff actually move from organisation to organisation, but if you have staff that actually move across different care settings, for example, from community into residential care, they'll already be trained. So imagine how valuable that would be. So just to recap some of the benefits that you actually get from using an inter-rai assessment system. So you have decreased duplication because you're only using the one assessment instrument. You're not collecting multiple assessment forms or multiple assessment risk screeners, which often have common items between them. And this provides an improved assessment experience for the client themselves. So you're not re-asking the same thing over and over again. There's also less training for more and improved information. So because the instruments are all evidence-based and research-based, and you're only providing training on the one assessment instrument, and that can then be used across different care settings or different organisations, then you're only having to train people once. It's a fantastic basis for decision support for care planning. You're identifying people's individual strengths and needs and then putting those to use so that you have person-centered care. It also provides early risk identification, and therefore we can put in interventions to prevent those risks from occurring. It provides consistency both across settings and also different jurisdictions as well. And as I've mentioned, the information is all reliable and all set out in the same way. And what this does is provide compatible data across different settings and different organisations, and also meets mandatory industry accreditation and quality goals as well. Thank you.
Good day. My name is Ronald. I'm a Health Informatics Research Fellow at the University of Queensland. For this part of the talk, I'll be describing our work on aligning inter-rai data to health data standards, and that is specifically SNOMED CT and FIRE. Now, I will not go into the technical details, but just provide a brief overview of that work. So to start with, the integrated suite of inter-rai assessment systems is designed for use in digital environments to facilitate data sharing and reuse of that data among providers using inter-rai systems, even though these providers may be using an assessment system that is specifically designed for their setting. And this is all a result of the principle of collecting data once and using it many times. However, at inter-rai Australia, we believe it's now time to expand that principle beyond the inter-rai ecosystem and start to build capability to share data with other health information systems, in particular, electronic medical and electronic health record systems. In order to achieve that, we need to align inter-rai systems with existing data standards that currently underpin health information systems in other settings. Firstly, those EMRs and EHRs in particular use terminologies to identify health concepts and to maintain semantic meaning of those concepts. Now, there are several such terminologies, but SNOMED CT is the primary and most prominent one in the industry. So much so, it is essentially regarded as the language of electronic medical and electronic health records. And it is key to achieving interoperable data exchange. This terminology system also extensively covers clinical and health concepts, and coding those concepts using unique codes that are arranged in a hierarchy in order to support health analytics at multiple levels. It is very popular, with a presence in over 80 countries, and that includes Australia. And so, looking at the common attributes for inter-rai and SNOMED CT, we see that both systems are comprehensive in their respective approaches. Both systems have scientifically validated content, and they both strive to achieve consistent representation of health data regardless of care setting where that data is captured or used. And both systems enjoy extensive uptake internationally. Now, of course, there are some differences. You will notice that inter-rai, in addition to having assessment content, they also have decision support outputs. The second difference is that inter-rai prescribes how assessments should be conducted, and those are some of the differences. However, the similarities that we see here have motivated us to explore how these two systems can work together. And indeed, our initial analysis has shown that the systems are complementary rather than competitive. On one hand, SNOMED CT is well established in the acute care sector, and on the other hand, inter-rai systems are well established in the aged care sector. Now, we are currently in discussions with consultants from SNOMED International and other inter-rai fellows to explore the technical details of how we can harmonize the two systems and leverage the strengths of the other within the other. And so, alignment with the terminology system like SNOMED CT is one aspect. The second aspect is data exchange standards, where we will need to specify the representation of inter-rai data and define the rules for their exchange between information systems. And in this area, we are looking at FHIR, or Fast Healthcare Interoperable Resources, which is the latest specification out of HL7. Now, there are several reasons we've chosen FHIR, both strategic and practical. And chief among those reasons is that FHIR is already being used in other healthcare sectors within and outside Australia. We also see its adoption by big tech companies like Amazon, Apple, Google, and Microsoft, as well as several levels of mandates for its use in large informatics markets such as the UK and the US, as indicators that FHIR will be the leading specification for health data standards for a considerable period in the future. Now, here in Australia, specifically, FHIR is becoming the cornerstone of the nation's strategies, various strategies for interoperability, and we also see that the department has not only invested in the SPARKed project that is being run out of the Australian eHealth Research Centre. It is also a partner in that project, and that project is building interoperability solutions based on FHIR. And therefore, we at inter-rai Australia are leading an effort to implement inter-rai systems in FHIR, and our goal is to rally the global inter-rai community to form an international collaboration to develop what will be an international solution. We've initially approached Canada, who have been collecting inter-rai data into a central database using FHIR in some provinces, as well as New Zealand, who are planning to do the same. However, we've seen growing interest in this work, as just in the last few weeks, we've received inquiries about this work from countries in Europe such as Finland, Switzerland, and Belgium. So once developed, an international solution out of this collaboration would then be customized for specific countries using FHIR profiles. So with successful implementation of these two streams of work, we would see real opportunities to extend the range of utility of inter-rai by facilitating compatibility with other health information systems, particularly electronic health records as well as electronic medical records. This would mean that such systems can consume inter-rai data and vice versa. It will simplify the transfer of assessment data across different systems and across sectors reducing the data burden on both the provider and the consumer in the process. It will additionally make inter-rai data usable in analytics applications, allowing software providers to be in a position to develop innovative applications using modern technologies such as Smart on Fire, and also to build artificial intelligence applications that can ingest inter-rai data in combination with data from other sources. And more importantly, it will help to improve the care and lives of our older people. That's all I have for today, but I leave you with these links to some papers that I think you will find interesting. So happy reading and thank you for your time.
In this final session, I'd like to share with you some thoughts about how we might apply inter-rai systems within the Australian Aged Care Program. This matter needs thinking about both from a within program, for example, in an RACF or in a home care program level, but also at a whole of system level. And I'll start with the use of the systems within the care planning environment. Organisations that are delivering care, there currently would be some kind of clinical assessment process occurring, and the types of kind of domains that would be covered would be things like cognition, moods, healthcare, and so forth, which you can see listed on the left-hand side of this slide. And most organisations would use that information to in some way construct a care plan, and that would in turn lead to, logically, some kind of task list to deliver the care to the individual. Thinking about inter-rai systems, you could just add an inter-rai minimum data set, an inter-rai system, to that arrangement, and that would be collected at some point where the regulator, that's the government, would want to see data. So, for example, in the current RACFs, there is quarterly reporting of quality indicators, so that point where reporting is required might be the point at which an inter-rai assessment could be conducted. We recommend an alternative arrangement, and this is one in which the inter-rai based minimum data set would be completely integrated into the clinical assessment process. And inter-rai assessments, as you've seen, cover off all of these care domains that are important for older people in an aged care program. So whilst the inter-rai based minimum data set doesn't provide everything you would want to record about a person, it does do all the essential assessments and also calculates all the applications that are required in order to develop a care plan and a task list. The advantage of this is that there is no duplication of data entry whatsoever, and information that's required for the regulator is already collected within the clinical assessment. So in an arrangement where clinical assessment processes have integrated inter-rai systems and minimum data set already in place, let's think about how the workflow could work. So the way we've been thinking about this is that upon entry to a program, there is an assessment, an inter-rai assessment is done. At some point after that, this could be a week or 4 weeks, when the needs of the person are really clearly understood, then the assessment could be finalised. And so at that point in time, data becomes available for exchange or reporting, knowing that it's stable, it's reliable, and it is based on a fairly reasonable period of assessment. Subsequently, ideally, any changes in status of the individual would be recorded in the whatever software that contains the inter-rai systems and the MDS, and would be kept up to date. And at the time when a periodic review is required, For example, at the 3-monthly QI reporting time, the plan is formally reviewed, checked that it's up to date, and virtually at the push of a button, the quality indicators are calculated and the information is reported to the government. Now, let's think about how inter-rai systems might be applied across the whole program. So the aged care program really can be segregated into 3 broad functions. One is inquiry. This is where individuals or families approach the aged care program and seek assessment and on the way to securing some kind of care. So inter-rai has a couple of tools that would support the inquiry function. One is called the inter-rai checkup self-report version. This would be an appropriate substitute for the self-assessment that sits on the My Aged Care website at the moment. A little bit more in-depth than what's there, but also it provides a lot more interpretations of what needs are. It also does some work around risk profiling. So it would provide a better kind of front-end suite of information for the subsequent eligibility assessment that would be conducted. An alternative is the inter-rai contact assessment. It's a pretty short type of assessment. It's done by an assessor. Doesn't need to be particularly highly trained, but it would be the sort of thing you could collect over the phone, and that would be the beginning of a process that also leads to an eligibility assessment. Eligibility assessments are done by aged care assessment teams in Australia, and they have a need for a standardised approach to assessment. inter-rai has 2 tools that would be suitable for that process. One is called the inter-rai checkup. It's a moderately sized assessment. It takes about half an hour to do. It would be most suitable for people that have got relatively low complex requirements. For individuals who are potentially going to receive an expensive package or who may end up in residential care, the inter-rai home care is a much more suitable tool. Bear in mind that the information embedded within the checkup is for the most part a subset of the information that's in the inter-rai home care, so that assessors could begin by doing a checkup, and if they encounter a level of complexity, could complete the whole inter-rai home care assessment in the same session based on their view of how complex the person's requirements are. And you can build in some decision support tools within the checkup that trigger the need for the home care. So some kind of arrangement like that would be what we imagine would be best practice for an eligibility assessment. There's a principle in there that you want to have the size of the assessment related to the complexity of the person's needs, and so that you don't do big assessments on individuals that have relatively uncomplicated issues. At the care delivery stage, there's currently the environment is one in which there's a home support program, people with low needs, low complexity. The checkup system would be suitable for assessment and care planning, and for persons that are getting packaged care, more complex, the inter-rai home care. And for those who are living in residential aged care, the equivalent document for a long-term care facility, the inter-rai long-term care facility system would be appropriate. All of these systems, as I've explained earlier in today's presentation, produce tools that support care planning, help with service administration, can be used to calculate case mix, that probably could be used to calculate the ANAC categories, in our opinion, and certainly they would be able to calculate quality indicators for residential care and most likely for home care, as they do in many other jurisdictions. So looking at these systems, recapping what I've just said, so the inter-rai contact assessment would be suitable for referral and triage, the checkup self-report for self-report on the My Aged Care website, the checkup itself for persons needing low complexity home care, For those who've got highly complex needs, the inter-rai home care, and for those living in residential care, the inter-rai long-term care facility. So to conclude this discussion, let's ask the question, why should we use inter-rai in Australia? Well, first of all, inter-rai offers applications that cover the entire aged care program. So you have the one approach to assessment and care planning across the whole trajectory that an older person may experience who is in the aged care program. The clinical decision support systems are fully developed, mature, robust, scientifically grounded, and they are available again in every setting. Same kind of decision support tools present in all of the instruments that inter-rai offers. There would be support for trainers and software developers. Given that the look and feel and the content of all of these assessment systems is similar, once trained in one system, it's pretty easy to understand and use another inter-rai system. And similarly, software developers would be able to build solutions for each setting using the same kind of logic, the same kind of design, the same content. The inter-rai systems, the checkup, home care, and long-term care facility systems are very suitable as minimum data sets for regulatory reporting. And indeed, each of those systems could be the core MDS, and then there's an extended MDS for each of the home care and LTCF systems where more data is available. We think the data is suitable for calculating the ANAC, and we are very confident that the majority of QIs can be calculated from an inter-rai assessment. And as I've said earlier in today's presentation, you can, once you do an inter-rai assessment, you can calculate a whole lot of quality indicators that are not currently in the mandatory QI program, and they all come effectively free of charge at the click of a button. And if we were to use inter-rai, we would join a very large community of nations that are using inter-rai. So we'd be in a much better position to compare our systems in terms of performance, clientele, and so forth with other countries with similar types of systems to our own. So that concludes our presentations for today. I hope you found this to be of value, interesting. I'd encourage you to think about the use of inter-rai in Australia, and if you have any passion for this, to try and promote these systems' use in Australia. If you want to know more, you can visit the inter-rai International website or the inter-rai Australia website at these addresses. So thanks so much for attending. It's been a pleasure to be able to present to you, and we're happy to answer any questions now or by email in the future. Thank you very much.